Hello, everyone. I'm excited that you will be listening to Megan's and my presentation on regulation of the autonomic nervous system as we talk about both sympathetic and parasympathetic modulators and how to really assess the autonomic nervous system and treat autonomic nervous system dysfunction and dysregulation.
So a couple of weeks ago, we were asked to watch the mobilization of the autonomic nervous system. And David Butler gave a really great talk, kind of just talking about a lot of the neurogenic pain and things like that. Within that presentation, there was a quote by Gordon Waddell that I thought was really relevant to what we were going to be talking about. And he says the emphasis of physiotherapy for non-specific pain should change from symptomatic methods, which have shown to be ineffective, to early activation and restoration of function. And this requires a fundamental shift in physiotherapy practice and resources. So, what I took from this quote is our fundamental shift in physiotherapy practice needs to be our consideration of the autonomic nervous system. When we consider this non-specific pain, chronic pain, or pain that just goes around that we can't figure out where the origin or the resolution is, there's something deeper there that we need to be considering. And so what we need to do is start to shift our mindset a little bit to how can we treat the autonomic nervous system before getting really into some of the pain that these patients are experiencing. So with that, we're going to kind of get into how we can start to do that. And this is obviously preliminary. This is stuff that we've kind of played around with a little bit in our own practice. And we're definitely going to be continuing to build on these concepts as we go. So to give you a little bit of an overview, today we're going to be talking about the key concepts surrounding autonomic nervous system dysfunction. We're going to be getting into the theories surrounding it because they're a little bit different than we learned originally. We're going to talk about how we assess autonomic nervous system function and dysfunction, some treatment options, and then we want to share with you guys a case study that we are currently working on. So when we consider the autonomic nervous system, we know that it's a branch of the nervous system that's responsible for all of the automatic stuff that happens in our body. So this is the involuntary regulation of organs and systematic function, our blood pressure, our heart rate, our respiratory rate. All of this is controlled by the autonomic nervous system. And it's intimately linked with function of the vagus nerve, which is our cranial nerve 10. And so what we're going to be talking about today is kind of how those two are linked together and how we can leverage the system to find success in our patients who are chronically upregulated and feeling the effects of this dysfunction. We want to focus on kind of the activity itself of the vagus nerve and how we can either do exercises or treatments to increase that vagal tone and bring someone into a higher social engagement state, which Michelle will get into in just a second.
So the old theory of the autonomic nervous system is that it was comprised of two primary branches, the sympathetic branch, which is that fight or flight response, and the parasympathetic branch, which is the rest and digest. There is also the enteric system that was included in that old theory as well, too. And disorders such as heart disease, anxiety, high blood pressure, were all arose because that parasympathetic activity was masked because activity of that sympathetic nervous system was so upregulated. And in that old theory, that vagus nerve was seen as just a primary single pathway that would just innervate all these different muscles. And it didn't really have a different function. Its function was determined based on what organ it innervated. However, in this new theory, the autonomic nervous system has three primary circuits. So we have the ventral branch of the vagus nerve, which is responsible for our social engagement system. We have our spinal sympathetic chain, which is very closely linked to the sympathetic response of the old theory, which is that fight or flight response. But now we also have that second branch of the vagus nerve, which is the dorsal branch. And that is our freeze response. And I know at least in the MSAT, we were introduced to this new concept. We talk about fight, flight, and then freeze. And this dorsal branch is really that freeze response. And with these three circuits, you have those three circuits, but then you can also combine them to create 5 possible different conditions of the autonomic nervous system that are really a combination of that ventral, that spinal sympathetic, and those dorsal vagal pathways. And then, similar to that old theory, right, dysfunction results from chronic upregulation of the dorsal or the sympathetic chain activity, because those tend to, you see those more with like depressive symptoms, whereas that ventral branch, that's more the social engagement. And so that is essentially being masked rather than the parasympathetic activity being masked. So this slide here shows the essentially breakdown of the autonomic nervous system, right? So we have that umbrella autonomic nervous system and the 3 primary circuits, the ventral vagus branch, which is that social engagement piece we talked about. And then we have the spinal sympathetic chain, and that's responsible for mobilization with fear, which is again, that fight flight response. And then you have the dorsal vagus branch, which is immobilization with fear, which is the freeze response. But now we have 2 additional circuits. So that first, or that circuit number 4, is mobilization without fear. And that combines the ventral vagus and the spinal sympathetic chain. So mobilization without fear, how we can kind of interpret that is in a competition state. So when you're in a competition, you're not necessarily afraid, but you are super mobilized and you are upregulated. And so that's what that piece is kind of considering. And then in stage 5, or that 5th circuit, you have immobilization without fear. And that combines the ventral vagus and the dorsal vagus. And how you can interpret that is feelings of intimacy, where you're immobilized, but you're not necessarily afraid of the state that you're in, because it's a state of security, a state of comfort. And then kind of going back to that 4th circuit, that mobilization without fear, one thing Megan and I were discussing was with the current COVID pandemic, a lot of sports teams have had to cram so many games in to make up for maybe competition time they didn't have in the fall. And so this spring, people are playing more and more games than they normally would. And so in a lot of our patients, you'll probably see autonomic dysfunction of their systems because they're probably in this chronic state of mobilization without fear, with having to be in competition mode so much and so often. And so I'm really interested to kind of see, once this whole COVID thing is done, and as students and patients are preparing to go, off and do whatever for the summer, all of a sudden I almost feel like there could be some potential crash there, because now they don't have to have this mobilization without fear phase, and kind of what that would be like and how our patients would respond to that. So that was just something Megan and I were kind of talking about to consider with our patients in light of the current global situation.
We also thought it would be kind of relatable with ourselves as clinicians, right? So, we're coming back and we're talking about even having to work during this COVID pandemic. And I know for a lot of us, they've tried to overload certain sports that were played in the fall into the spring, and many of us are working beyond our normal hours. And, I know personally that feeling burned out has been kind of a constant ever since February. And so it will be interesting to think about, are we as clinicians also kind of living in this state of mobilization without fear as well? So looking forward to kind of getting everyone's thoughts on that.
So Stephen Porges is the one who initially came up with the polyvagal theory back in 1995. So it's not necessarily even though it is recent, it's not as recent as one might expect. And in the polyvagal theory, as I mentioned, that vagus nerve is divided into 2 branches. We have the ventral vagal branch, which arises from the nucleus ambiguous on the front of the brain stem, hence the term ventral, because that's the location of that branch. And it functions very closely with cranial nerves 5, 7, 9, and 11. And when you think about social engagement, like instinctively to me, I think about, the face and the facial muscles, facial expression, facial emotion. So it makes sense that it would be so closely linked to cranial nerves 5 and 7. And then you also have the dorsal vagal branch, which arises from the fourth ventricle, and that's a little bit more posterior, hence the dorsal location of that branch and the dorsal name. And again, these two branches are, they produce different states of immobilization, emotional responses, organ functioning. And so when they're not in balance and when they're not, functioning the way that they should to for optimization, that causes that dysregulation. And then the pictures just show you again the different organ systems and the different locations and innervations of these two different branches of the vagus nerve. There's like the facial muscles versus the organs within the body as well.
So when we stop to consider really what dysfunction of the autonomic nervous system means, Stanley Rosenberg, who wrote the book called Assessment of the Vagus Nerve, and kind of like how we can focus on um, we can focus our treatments on kind of treating the vagus nerve and like healing in that way. He brought up a really cool metaphor talking about Hercules and the heads of the Hydra. And for those of you who may be unfamiliar with this Greek lore, it's the story of how Hercules and Hydra, who is a water beast, came together and had this big battle. And the Hydra is a obviously multi-headed water beast. And Hercules learned pretty early into the fight that every time he cut off one of Hydra's heads, two more would grow in its place. However, one of Hydra's heads was mortal. And so after a while, Hercules was able to finally cut off the mortal head of Hydra and thus kill the beast. And so the metaphor basically speaks to how we deal with patients who come in who just have all of these symptoms. And all of these symptoms, even though they are very real, they can never really point to one specific problem. And so when we consider dysfunction of the autonomic nervous system, it's these issues where patients will come in and they'll have one pain somewhere, and then they'll treat that, and then they leave feeling okay, and then they come back with something else. And I kind of refer to it as like this popcorn pain, where it just goes from one place to another with really seemingly no origin or resolution. And so these can manifest in multiple different ways. We have our physical issues, which is typically going to be more of a chronic pain pattern. This manifests particularly with like low back pain, arthritis, chronic musculoskeletal issues. But then it can also manifest in emotional and visceral and relationship issues. So, one thing that we're going to kind of be talking about is the mental health aspect of things. And that's very intimately linked with physical dysfunction. So if someone's in pain all the time, it's going to take a toll on their emotional well-being and their emotional health. So they may be more irritable. They may have a lack of energy. They may feel depressed. They may feel anxious. And all of these are very, very real to our patient because they're experiencing it every day. And so as clinicians, obviously this is not an exhaustive list, and this, a patient could come in with a couple of these, all of them or none of them. But it's just important to be aware of them and how autonomic dysfunction can really affect someone's entire life rather than just the physical that we typically see in athletic training. So, when we get into how to assess it, um, it seems kind of at first glance that autonomic dysfunction is one of those things like, well, how are we ever going to figure out besides symptoms? It actually turns out there's a couple of cool ways to do it. So, Stanley Rosenberg wrote this book, The Healing Power, Accessing the Healing Power of the Vagus Nerve. And in that, he talks about this test called the levator veli palatini test. And the levator veli palatini muscle, it's actually two muscles on either side of the uvula. And when stimulated by part of the pharyngeal branch of the ventral vagus nerve, as Michelle talked about, it actually raises the arches of the soft palate. And so when we're eating, It's what actually rises up and allows food to pass through from the mouth to the esophagus. So the levator veli palatini is actually a really cool way of determining what ventral vagus nerve function looks like. And if someone's dysfunctional, you might actually see that those muscles are either asymmetrical or delayed in their response to certain stimuli. And so there is a test that we can use. And basically, what you do is you have the person open their mouth. Michelle and I have used pen lights to look into the back of their throat. And you basically have them perform a very distinct ah sound. And you have them repeat that over and over and over again. And what you're looking for is those two muscles to raise up, and you want them to be symmetrical. If they're asymmetrical, if they're delayed, if there's no movement whatsoever, that may indicate that there is some sort of dysfunction of that pharyngeal branch of the ventral vagus nerve, and that could potentially link to autonomic dysfunction if you are seeing other symptoms as well. And Stanley Rosenberg talks about how typically, if he has a positive LVP test, he also has that same patient is dysautonomic with breathing as well, which we'll get into. So, I want to get into a case that I actually have with one of my patients at the high school. He is a senior this year and facing, a lot of this kind of typical stress that college seniors face, in addition to COVID. And so he has been dealing with some chronic hamstring issues ever since soccer season. He is a multi-sport athlete. He does run track and field, and so he's kind of in the thick of his season in track and field right now. And so I think in addition to dealing with a lot of the academic student patient stresses that he's going through, he's also dealing with this, what I would really consider kind of like a ghost hamstring issue, because there's nothing physically wrong with the hamstring, but he can feel it pretty frequently. So as we were talking, I had, started to really get into the thick of learning about this stuff. And, it was just this component of playing in my practice. And I said, "Hey, do you mind if I play around with some of this?" And he said, "Yeah, definitely." Um, so this is the first video that we're going to show, and it's going to be the pre-assessment. And so I had done the LVP test. I did the high-low test for breathing, which we'll get into. And I took him through the state trait anxiety inventory, which is a present tense reported outcome measure. And so this is what the LVP looked like prior. And so as you can see, there's just not really a lot of movement there. And it was kind of a case where I was like, well, I'll video it and I'll see if we can produce any meaningful change. Um, when he's making that ah sound, and um, in the future, I'm going to do this a little bit differently because he was a little bit too short. Um, there's just not a lot of movement of those muscles there. And so if we come into the post, this was after treatment using the basic exercise, which we'll get into, as well as the clamshell exercise. Um, see if we can tell a difference here. So it's minimal, but it is there. You can see kind of those muscles are arching a little bit more. And again, like I said, I'm going to change this up because he was very staccato and very fast. So it was hard to really tell what was going on. But regardless, it was something that we tried and had good success with.
And you can
Oops.
also see too um, the deviation of the uvula as well too isn't quite as severe post the basic exercise and the breathing intervention as well too, which is interesting to note. So there was some sort of change happening there.
So, getting kind of more into the breathing aspect of things, Koki did a fantastic job with our last presentation talking about why we should consider breathing in our clinical practice. And so we'll touch on this really quickly, but one of the things that we want to really make known is that when we consider autonomic dysfunction, breathing is absolutely something that we need to be considering. We need to be assessing the patient kind of as soon as they walk in the door. What does their breathing look like? if we're using a high-low test, if we're using the MARM, if we're using the Nemesian questionnaire, we want to look and see, does this patient have synchronized motion of the upper and lower rib cage? Does their abdomen move? Are they using their diaphragm properly? And if they're not, again, this is kind of one of those things where we're looking at multiple symptoms. Does it match up? Could this patient potentially be dysfunctional within their autonomic nervous system? So individuals with that asymmetry of the LVP are typically displaying dysfunctional breathing as well. And so, in the case with the patient that we just showed you, he had a little bit of an LVP positivity, and then he also displayed dysfunctional breathing. When I did the high low test, he was apically breathing through his chest.
Another way to assess dysfunction of the autonomic nervous system, which has been studied fairly intensively in the literature, is using heart rate variability. And heart rate variability assesses ventral vagal activity, because when you have high heart rate variability, your body is able to make micro adjustments based on the social situation that you're in. So if you have high social engagement, is going to make a lot of micro adjustments accordingly. And so in order to assess this, you can have really fancy technology to make precise measurements of heart rate variability, but you can also just do a basic test on yourself, and you can actually walk your patients through this as well too, and see if your patients notice their heart rate variability. But for this instance, what you would do is you would take a breath in and just pay attention to, you could either measure your pulse on your wrist or just feel your heart beating in your chest. And when you breathe in, you should feel a slight increase in your heart rate. And then when you breathe out, you should feel a slight decrease in your heart rate. And that shows that you do have some heart rate variability going on, just as a quick assessment to make sure that you do have some, because high heart rate variability, again, is what you want, because it means you have regulated ventral vagal activity. For people who have decreased heart rate variability or low heart rate variability, they typically have other comorbid conditions such as obesity, high blood pressure, PTSD, and COPD. So that's just another tool for you all to use. So now we're going to get into some of the treatment options that we have for the autonomic nervous system. And all of this is pretty much primarily focused on activating that vagus nerve, primarily that ventral branch, because again, we want to bring the body from a state of dorsal activity to ventral activity to have more social engagement. So for those of us who were in the MSAT, we took all 3 courses of MYK, and we learned in that 3rd course about how to treat different aspects of the autonomic nervous system by combining the treatments of, upper body, lower body, and thoracic as well too. So for those who have not taken that course, we will be taking it eventually, but that will be a treatment option once you learn those as well. There's also vagus nerve stimulation, and this would be more of something that you would refer out to have that treatment done. It's not necessarily something you would likely do in your clinic or in your practice, but it is just something to point out. Typically, this would be recommended for patients who have, say, epilepsy, to help bring them back into regulation as well. And as Megan mentioned earlier, when she was doing that assessment on her patient with the LVP test, she used the basic exercise as a treatment. So I'm going to now tell you what the basic exercise is. So the picture that you see on the slide, that is the positioning of the basic exercise. So the patient will be supine in a position that's comfortable to them, either on the table, ground, whatever they're most comfortable with. And they're going to interlock their fingers together and place their fingers behind their head and put pressure and essentially apply pressure. So that way the back of the head is almost pushing into those fingers. And in that position, you're going to have your patients, without turning their head, turn their gaze to the left, and they will hold that position for 30 to 30 seconds to 1 minute. Then you're going to have them again, head staying stationary, just shift their eye gaze to the right, holding that for 30 seconds to 1 minute. And you're going to see what their response is afterwards. Typical responses after the basic exercise include sighing, yawning, or swallowing. So you can ask your patients after you do this treatment, what did you experience? And then they should be able to tell you. And again, this is something that you can measure pre-post with that LVP test. And how it works is it helps to reposition the atlas/axis to help increase blood flow to the brainstem, which we know the ventral vagus nerve is on that brainstem. So it helps bring blood flow to that nerve as well. Breathing, as Koki mentioned in his presentation as well, to the clamshell is a really great exercise to help bring the patient from a breathing pattern disorder, which could be indicative of autonomic dysfunction, back to a more regulated state to help that autonomic nervous system kind of reset. Mindfulness and meditation, especially, our energy medicine techniques as well too, those have been shown to help, decrease emotional exhaustion. So that will take a person from that dorsal vagus state to a ventral vagus state to that social engagement area. And then a final treatment that will be explained in a future presentation from Jason, or Jay Beebs, as he's affectionately called by some of us, is associative awareness technique. And he will go into more detail with that as well. But essentially, that technique is also used to help bring the autonomic nervous system back into regulation.
So we've talked about a lot here in this presentation. Hopefully it was a good overview as to kind of what the ANS is, why it being in dysfunction is an issue for us clinically. And hopefully it was, some new information that you can take back to your practice. So I want to hit on just some quick key takeaways as we go here. And hopefully you can take what you've learned here and bring it right to your clinic, and hopefully maybe identify someone who is struggling with this. But the biggest thing that we want to kind of take away is that we need to be considering it in our practice. And it's one of those things where, we talk about patients who come into our clinic and maybe we call them frequent flyers, maybe we call them attention seekers, maybe it's a patient who just always seems to be hurt and nobody really knows the reason why. And we talk about the importance of getting to know our patients and the importance of taking them at their word when they say something is wrong. And a lot of the times, this has kind of filled in that uh, you know, that so-called puzzle piece for me, where it's like, okay, well, I can't find anything wrong with them, but they're hell bent on saying something is. So instead of writing them off and saying this person's a drama queen who just wants the attention, maybe they have something going on. Maybe they're upregulated, and maybe we need to consider what their autonomic nervous system is doing. What else is going on in their life that could be contributing to their pain. And so, overall, it's something we need to be considering when evaluating and treating those patients who display anxiety or depressive tendencies or that malingering pain. So that's probably the biggest one. And the second key takeaway is that, contrary to popular belief, evaluating these autonomic nervous system deficiencies can be very simple and very effective. And clinicians who come from all walks of life and levels of experience and whatever their resources are, they can be using these techniques because they really are very simple, as long as you're kind of taking these things into consideration. And lastly, Michelle had talked about there's an array of treatment options for clinicians to use that can help to increase vagal tone and regulate the ANS and bring someone back into that state of social engagement. So these are all things that we can kind of start to consider. Hopefully, this has filled in some of the gaps that you may have. Maybe you're thinking of a patient right now that could really benefit from this stuff. So we hope you enjoyed this presentation. We hope that you took some things from it.
And we really look forward to, having a conversation with you all in class about these different assessment techniques, what questions you have. Maybe you can try this on a patient before we actually discuss it in class, and then bring your experience and we can dialogue about that as well. We're also sending along Stephen Porges' polyvagal theory article. So if you have more questions about the polyvagal theory, feel free to read that. We also definitely recommend the Stanley Rosenberg Assessing the Healing Power of the Vagus Nerve. It's a super easy read, but very informative, very engaging as well too. That's a lot of what we based our presentation off of. But yeah, we all just look forward to hearing your thoughts and questions, and opening up this new avenue that maybe this is something that's been missing in your clinical practice and will really help a lot of your patients.
Thanks for listening.
Thank you.